So most of you know me who are here in person. Those of you that are on Zoom, it's nice to meet you virtually. My name is Sundeep Bola. I'm a pediatric sleep physician and respirologist. And today I was going to talk about clinical cases that we have seen in my community practice. And so we'll get right to it. So I don't have any conflicts of interest to disclose. What I'm hoping...
Can you just use the mic because no one can hear from the back?
Which mic?
Just keep it little close.
Okay. Is that better?
No.
I really don't want to put on my mouth.
Okay.
Yeah, I'm not going to do this.
Just little loud there.
So, what I'm hoping to cover through this talk is going through these clinical cases, hoping that you can, by way of these illustrative cases, appreciate the nuances in evaluating and managing pediatric sleep medicine beyond simple OSA, and then looking and appreciating the potential role of sleep studies beyond what we're doing them for. So beyond sleep medicine, we are monitoring a number of different things during polysomnography and appreciating that we may pick things up outside of that. So back to the talk here. So physiologic central sleep apnea. A big breath. So you take a big breath and then you hold your breath after. It's common, it's physiologic, it's a response to a big breath. You have an arousal in your sleep. So you have a post-arousal central apnea. Generally speaking, the index here is usually less than 5 events an hour. You can have central lesions. So we talked about this. Arnold-Chiari malformations or a tumor, anything that's really affecting the respiratory centers can lead to central sleep apnea. Central sleep apnea associated with cardiac conditions, more common in adults, as I'm sure all of you know. It has been described in certain cardiac conditions. Endocrine conditions, so there's something called ROHAD, which is rapid onset obesity with hypoventilation, hypothalamic dysfunction, and autonomic dysfunction. It's relatively uncommon, but something to consider when you see it. And then it's been described in hypothyroidism. Genetic conditions, so something called CCHS, congenital central hypoventilation syndrome. You can see central apneas in that. It's associated with hypoventilation, and we don't know if this child hypoventilates. And then central sleep apnea associated with other sleep disordered breathing. So, for example, obstructive sleep apnea. So these are the big categories that are in this table. So now, investigation. So we're going to use that table to guide our investigations, right? So MRI brain and brainstem, that's important. Let's make sure he's not got a tumor or a Chiari, right? That's normal, so that's good. Echocardiography. This is useful for 2 reasons. One, you want to make sure, clinically, you pretty much know that he doesn't have a cardiomyopathy or something that's compromising his cardiac output to the point to give him these central apneas. You would know that clinically. But it's also useful to know that there's no sequelae from his underlying sleep disordered breathing, so no pulmonary hypertension, which is great. And that makes us more comfortable at trialing PAP at home. Endocrine assessment. So we do some lab investigations. We check hypothalamic function, and I added a serum bicarb. Ideally, I would have liked to have done a venous blood gas. The family couldn't, in terms of limitations of being in the community, you can't do a venous blood gas at any life labs because the sample has to be put on ice immediately, and so they don't do it. So you can do a serum bicarb, which would be elevated if there's a chronic acidosis. It can be helpful. Excuse me. Pulmonary function test, it didn't really adhere any sort of benefit. He had mild reversible obstruction. The technique was questionable, and so on. So we've now seen it's not a central lesion. It's not likely not an endocrine issue, and it's not a cardiac lesion. So we'll try him on CPAP. Let's treat his obstructive sleep apnea at bare minimum, and let's see what happens with his central apnea. So he does very well with his auto CPAP. He acclimatizes, and we see on the downloads that his AHI is well controlled. So we bring him in for a CPAP titration. 11 centimeters optimally controls his underlying sleep disordered breathing, both the central and the obstructive sleep apnea. And so now we know what's the reason or what's the etiology of his OSA and his central sleep apnea. So His OSA is adenoids and tonsils and obesity. Excuse me, and his central sleep apnea is likely because of his OSA. So what I mean by that is his OSA is causing sleep fragmentation, and his central events are happening when he's going from sleep to from wakefulness to sleep. And so he's having this exaggerated response to these big breaths. And when you look at the sleep study, you'll notice when he falls asleep, he takes a big breath and then he holds it. And then he starts to breathe again, snores a bit, big breath, holds it. So he's got increased upper airway resistance that's fragmenting his sleep, leading to these large breaths and then these central events. I don't see this commonly. I suspect that some individuals are just predisposed to this type of ventilatory instability, and he certainly was. So you remove the obstruction and you treat the OSA, but you also remove what was precipitating these central events. The reason that's important is because going ahead with tonsillectomy to treat his OSA, I find it's easier to convince an ENT that it will help with the central sleep apnea when you've demonstrated that relieving the obstruction by way of PAP also resolved the central sleep apnea. And that's exactly what happened for this young man. So he had tonsillectomy, his snoring improved, daytime energy improved, and he was having much more restorative sleep. And sometimes they don't even know that they're like these children won't even know they're going to feel better until you actually treat it. Because they tell you they feel fine when they wake up. Then they get treated and they're like, oh, that's what it feels like to get a good sleep. And so this is his post-op sleep study, still fragmented, but you'll notice, he told me he was fragmented because he was very uncomfortable with the study setup. But you can see, despite all that fragmentation, there's no central events at these periods of transition from wakefulness to sleep. So that instability is gone when his upper airway resistance has been improved or resolved, increased upper airway resistance. It's a limited study because he didn't get very much REM sleep, but it's clearly better, and the central events were non-REM predominant, clearly, right? So it was gone, and this is a good contrast. Again, the hypnogram doesn't project terribly well, but you can see frequent desaturations, lots of blue hash marks, a few pink ones here. There's really nothing happening. Stable saturation, no hash marks. He's markedly better. So, like I said, no evidence of sleep disordered breathing on his post-op study. And I mentioned maybe underestimated due to reduced REM sleep. That's from an obstructive perspective. From a central perspective, not an issue at all. Okay, so this is the last thing I want to do, and I think we've got lots of time. So this is just something I call it quick hits, because I'm just going to show you some quick epochs, and then I just want anybody, you can turn that speaker back on if you want. So if anybody wants to say what they see that stands out on this epoch, if there is anything at all. And the red line that's in the middle is not obscuring it.
K alpha.
Sorry?
K alpha.
Okay. Anybody else?
Irregular rhythm on the EKG.
Okay, I've got irregular rhythm on the EKG. Okay. Anything else about the irregular rhythm? That's good.
It's regularly.
Okay, perfect. So K alpha irregularities on the EKG. We'll leave it at that for now. Oops. And then 2. Anything?
I can make it mute.
No, I was leaving it there in case someone was going to answer from outside.
Okay.
Just leave it, it's not too loud.
Okay.
Okay, anything here? Yeah, sorry.
Heart block.
Perfect. All right, we're going to look at that one in a minute. Anything here?
Nothing. Only one little.
WPW.
Who said that?
Raymond Gottschalk.
Dr. Gotcha.
Yeah.
You've stolen my thunder. All right. Excellent. So, going back to the quick hits. Oh, this line is very irritating. So, somebody here had said irregular rhythm, right? So, that's the key here. Just identify, you're going through the CPOC, okay, something's wrong on the EKG, let me take a look. And then you've got some. Sorry. Can you please mute your audio? It's really disruptive.
Okay, let me just mute
No, because
that
the other
person.
part is, oh, can you mute them?
Yeah, let me just mute that person.
No, because if people want to, people should be allowed to interact appropriately, right?
Allow participant to
You have to.
Okay.
Did you mute everyone?
Yeah.
No.
But they will unmute by themselves when it
Oh,
is
okay.
needed.
Okay, they can do that though.
Yeah.
Still. Okay, perfect.
Yeah, we can unmute. That was great.
Okay, thanks, Kevin.
Yeah.
Awesome. Okay, so yeah, so we see it's irregular, open it up, slow it down, take a look, and this child's got frequent PVCs. If you look here, there's about 20 beats and 6 PVCs or something, so it's about just shy of 20%, which is quite frequent. The cardiologists tell me that more than 10% is worth being concerned about. So that's one. So frequent PVCs. This is very common. We see it all the time. Occasional PVCs here and there, generally not an issue. I'll mention it, but if they're relatively frequent, we'll talk about whether they need a formal EKG and maybe even a Holter and a cardiology assessment. So that's one. Very common. The techs are excellent at picking this up, and I think it's pretty clear. So the second quick hit. So someone had said heart block, right? So I just want to draw your attention to something. There's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30, 31, 32, 33, 34, 35, 36, 37 P waves, and 2, 4, 6, 8, 10, 14, 16, 18, and 19 QRS complexes. So there's a lot more P waves than there are QRS complexes. And it's not, what's really concerning is that there doesn't really seem to be an association between the P waves and the QRS complexes. Here we've got 3 consecutive non-conducted P waves. It's not just any kind of heart block, it's a concerning kind of heart block. I mean, to me, I'm not a cardiologist, but there doesn't seem to be a relationship between the P waves occurring and then the QRS complex happening. So that's important because we do see frequent heart block. I think the adult sleep physicians likely see much more cardiac stuff than we do in pediatrics, just because cardiovascular disease is so much more prominent in adults. And I find from speaking to my adult colleagues, and please, anyone on the Zoom calls, correct me if I'm wrong, but a lot of the time it's known, it's pre-existing. So you're seeing something that you already knew they had. But in kids, oftentimes that's not the case, except for congenital heart disease. We see lots of like bundle branch block in these kids with congenital heart disease. But oftentimes, like these cases that I'm presenting now are previously healthy children with no known cardiac history. So in terms of AV block, here's a bit of a refresher. I've got the, if anyone's interested in looking at this further, the sources down here. This is from the Merck manual online. But you've got first degree heart block, which is basically your PR interval is very long, right? So you're not having any P waves that are not being conducted. You've just got a long time from your P wave to your QRS complex. And to be honest, the way I find that this is easiest to identify on a sleep study is that the P wave happens so close after the T wave. It's and that doesn't mean that that's what it is. And we cannot measure PR intervals on our EKG. The software is not so refined. But you can eyeball it, and if you see it, it's worth getting a formal 12 lead. So that's first degree heart block. Second degree heart block comes in 2 flavors, type 1 and type 2. Type 1, very common in children. Wanky back, which is basically your PR interval gets longer until you drop a QRS complex. So you can see your PR interval here is shorter than it is here, so it's getting longer, and then you drop a QRS complex. And then you see again the PR interval is short again as compared to the one just prior to the drop complex, and it gets longer again, and then you drop a complex. that's a wanky back. The PR interval gets progressively longer until you drop a QRS complex. I do refer these kids to cardiology just to get the okay, but oftentimes they tell me it's nothing to worry about. And then you've got this type 2, which is, it's not that the PR interval is getting longer, but there's a rhythm to how often you drop the QRS complex. So it's like 1, 2, 3, drop, 1, 2, 3, drop, 1, 2, 3, drop. So that's a 3-to-1 heart block, and that's a second degree type 2. And then you've got your third degree heart block, which is basically there's no relationship between your P waves and your QRS complexes, right? And oftentimes when you have third degree heart block, you've got an escape rhythm. So your atria is not communicating to your ventricles, so somewhere else in the heart will pick up to keep a rhythm. This is, I'm told by my cardiology colleagues, the most concerning and the most dangerous in terms of sequelae and sudden arrhythmia. So this patient it's not clearly not a first degree, clearly not a second degree. It looks to me like it's third degree. When I talk to the cardiologist, they tell me it's not exactly that, but worrisome enough that the child had to be seen immediately. So they saw the child, like when we reported the study, I called cardiology, sent them the screenshots, and they saw the child right away. And then, unfortunately, that child never came back. So for follow-up. So I'm not sure what happened, if they ended up needing pacing or what have you, but she didn't have sleep apnea, and we called the family and they said we're good, and cardiology's following us at sick kids, we don't need to come back, and that was fine. So I don't know what happened to the child long term, if she needed to be paced or what. And then this last one is the one that Dr. Gutchuk hit the nail right on the head. So basically, and the reason I brought this one up is because I expected the room to be quiet, which is what happened here. Not remotely, but what happened here. And that's because on first cursory review, there's really nothing to be as obvious as what we've seen on the previous ones. It was clear there was some irregularity. There was something that made us say, okay, let's look at that EKG a bit closer. So here, when you actually look at the EKG, this just looks a bit odd, right? It just looks a little bit wider than you'd expect, right? It doesn't have the bunny ears that we see in bundle branch block typically, but it just looks, or at least right bundle branch block, but it just looks a bit odd. And then when you blow it up, you'll see, oh yeah, there's really no PR interval, and this slopes. See that? It just sort of slopes up. There's like an angle there. It angles up, and then the QRS complex starts, right? So no PR interval, and this angles up. So it sort of slurs the QRS complex. And that is classic for WPW. So basically WPW, again, I'm not a cardiologist, I'm not an expert here, but these are things that we see in our lab, and this is first presentation, right? This child has no known cardiac history, no cardiac symptoms, but we just see it, we pick it up because we monitor stuff. And so, it's an accessory electrical pathway between the atria and the ventricles, and it causes this sort of slurring up right here in the QRS complex, and that's called a delta wave. And then the PR interval is very short. It's basically non-existent. And so if I go back here, you'll see that's exactly what's happening, right? So right here, there's like no PR interval. It goes right into that delta wave, and that's diagnostic of WPW. And why do we care? Common cause of SVT, which can be symptomatically distressing and rarely can lead to atrial fibrillation. So that's why we care. And the last thing I want to show you is just if you look at these PR intervals, right, just to highlight this, and you go back and look at our other studies, you can see, right, there's like a clear, the P wave ends, the QRS complex starts, and it's sharp. Q is sharp, RS, right? And look at the other ones. So if you don't look at the PVCs, but you see it's like there's an interval, and then it's very sharp. There's no slurring, right? So this we actually had two of these patients sort of in close proximity to one another, I think within the same 3 or 4 months. Both of them referred to cardiology. Both of them had ablations to deal with that accessory pathway. So in terms of like what's out there in the medical literature for EKG findings on sleep study in children, there's really not a lot at all. So I found this study from 2021, and they reviewed 1,235 studies at Seattle Children's. 24 of those patients had some EKG abnormalities. They were all either PVCs, which we see frequently, and I've never seen a child have that amount to anything from a cardiac perspective. They'll get evaluated, they'll say, we'll follow this, but they don't really need to do anything. And then AV block. Wanky back, that type 1 second-degree heart block, I see that very frequently. Again, amounts to nothing. When cardiology sees them, they're happy, they sign off. And so basically, these guys, after their 1,200 or so studies, said about 2% of kids will have an abnormality. None of them were found to have any sort of structural or conduction abnormalities after referred to cardiology. And so I highlighted this. Our study supports that EKG abnormalities are rare and not associated with cardiac disease or sleep disorder. And the reason I highlighted that is because there's just not a lot of literature out there. This is the most recent study I could find from 2021 with more than 1,000 kids and really nothing found. And just going through the few cases that we've seen, there is pathology out there that you may come across, and we do a real service for these children when we pick that up, because it can be very important from a morbidity mortality perspective for them. So I just wanted to highlight that piece, and that's pretty much it. So I'm hoping that we've achieved these objectives, right? So the nuances in evaluating and managing pediatric sleep disordered breathing, right? So the major nuances we were talking about is, central nervous system lesions can cause OSA. Scratch your head if the child doesn't fit, right? If the story doesn't make sense and they've got sleep disordered breathing, but you don't really understand why, we should look into it further. And then appreciating the role of sleep study beyond sleep medicine. And I know Colin is going to be doing EEG stuff. So I had a number of EEGs I wanted to share, but I thought, we'll leave that with Colin and I'll just focus on the cardiac stuff. And that's pretty much it. So hopefully that was helpful. And I think we've got a few time. Yeah, a little bit.
Questions and answers.
Yeah, question and answer.
Ask anybody on Zoom.
Yeah, anyone, if you have questions remotely on Zoom, feel free to call in, comment.
Can I ask a question?
Yeah.
Hello?
Yeah, I can hear you.
Okay, Dr. Bola, about your first case. So I conclude that you referred that child, 1-year-old child.
Sorry?
Do you hear me?
Yeah, I can hear you. What was the question?
I'm asking about your first case, that 1-year-old child.
Yes, yeah. What's the question?
So you don't refer that child for PSG, and you just use the pulse oximetry to find out some oxygen desaturation about that child. And because of that severe desaturation, you referred him or her to the ENT surgeon, yes?
Yes.
Correct?
Yeah, so in a 1-year-old child.
According to our books in ENT, so if the child has severe, moderate, or severe AHI, this is the first indication for adenotonsillectomy. So, so in this case, shows up that even severe desaturation is a cause for adenotonsillectomy. Am I correct?
I'm not 100% sure I'm following the question.
Is our technologist.
So
he was ENT in Iran.
So I'll let me just make a comment and tell me if I've answered, because I'm not sure I followed. He's 1 year old. So the first part of the question was doing a polysomnography. We can't do it in a 1-year-old in the community.
Yes.
And the wait times are quite lengthy to get that done in a tertiary center in the GTA. So overnight. So typically, what I'll do is I'll put the referral in for a sleep study in parallel with doing the oximetry. If the oximetry is completely normal, it does not rule out sleep apnea. So we'll wait on the sleep study, or we'll treat empirically with nasal steroids. If the oximetry is abnormal, with the clinical history and the physical exam, that supports a diagnosis of OSA. And so then, yes, I would say that that is a very reasonable indication for adenoid tonsillitis. Does that answer your question?
Yes. And can I ask about what kind of surgery that case undergone? Is it adenectomy alone or adenotonsillectomy? Because at that age, adenotonsillectomy is relatively contraindicated, not absolute contraindication, but relative contraindication, because she's very young, 1 year old, is a relative contraindication for adenotonsillectomy.
So yeah, he underwent adenotonsillectomy, and I defer to my ENT colleagues in terms of deciding which intervention would be most appropriate. But I certainly would support adenotonsillectomy in a child with that degree of desaturation in the setting of adenotonsillar hypertrophy.
Okay, thank you.
No problem.
I have a couple of questions. This is Dr. Aldabag.
Yep.
Okay, first question. Hi, how are you? First question, with this COVID issue and the kids a lot of in the internet and being not sleeping very well, we're seeing a lot of kids with insomnia. I don't know what to do with them, effect on the school performance. Basically is the sleep hygiene. And second question, kids with obesity, do you start CPAP or you start something like some motivation for any intervention?
So the first question I think was about insomnia during the pandemic. Is that right?
Correct.
Yeah. So I'm not sure what the question was, but for the pandemic, I think in my clinical experience, and I'm sure yours and many other providers, can be anxiety provoking for a number of children and teenagers. You're right with sleep hygiene. I mean, with remote learning, again, my anecdotal experience has been there's been a lot more screen exposure, which has compromised sleep habits and hygiene. So that's certainly a very reasonable place to start. And then again, anecdotally in my experience, addressing and managing the anxiety either with a mental health professional or a primary care provider is also important, because that can certainly compromise their sleep and falling asleep. And then there's in younger children, your toddler age to early school age, oftentimes behavioral sleep disturbances sort of creep in, and so using behavioral modification can be helpful. I don't know if that's exactly what you're asking, but that's that piece. And then in terms of obesity and starting CPAP, you have to do that on a case by case, right? So if you're obese and you've got very mild OSA, no real impact on your day-to-day function, no comorbidities of concern, I think, yeah, weight management is a reasonable approach. But if you've got mild OSA, comorbidities, and you're profoundly obese with no adenotonsillar hypertrophy, maybe you talk about CPAP in that situation. The less ambiguous situations are you're profoundly obese, severe OSA, no adenotonsillar hypertrophy, then yeah, you move ahead with CPAP. But I find most children don't fall into that unambiguous situation. There's sort of, there's a gray zone, and you have a conversation with them about the risks of leaving OSA untreated, the risks of obesity in general, the benefits of PAP, and then adenotonsillectomy is still an option in obese children with OSA. I just talked to families about how the rate of persistent OSA is much higher in the setting of obesity than in the setting of non-obese children. So it doesn't matter what we choose. I always discuss the importance of sort of healthy lifestyle choices and by way of physical activity and healthy dietary choices. But we all know that that's not an easy thing to use as a single modality.
Your time is up.
Excellent. All right. Thank you, everyone, for your attention.
Thank you very much. Very good talk.
All right.